Welcome back to Shift Talk. I'm Brett. With me as always,
I'm Cody. I tried to jump the gun there. I'm sorry.
Hey, you did. Today we have a very special guest with us from the Office of the Medical Director, Dr. Cody. Welcome, sir.
Good morning. Thanks. Appreciate you having me.
So we wanted to bring you in for a few things today. Firstly, we want to talk about our field termination decision making, a little bit about some DNRs and Advanced Healthcare Directives, and then some sensitivity issues with family when we're on scene of these calls.
Absolutely.
Let's start with a little introduction. Some people may know you, a lot probably don't. So tell us a little bit about yourself.
Well, I'm an ER doc by training. I've been doing EMS forever, as long as I've been doing emergency medicine. Started out my career at MSTAT down in Norman, did that for about 15 years or so, and then had a mid-life career change. So I came up to Oklahoma City, started working at St. Anthony, and then they brought me on to the OMD to mainly do mobile integrated health with the fire departments in Oklahoma City and Tulsa. So that's primarily where I focus, and then just help with some day-to-day things as needed.
Right on. Well, doing a little Google digging, we may have found a little bit of your past. Someone was maybe in the music industry to some extent.
Yeah. So back in the day when I was trying to decide, what career path to take, I felt like I wanted to go to medical school, but I didn't feel like I was smart enough to get in. And so I wanted to have a degree where if I didn't get into med school, I would still have something I enjoyed. And so I studied music. And, I had a lot of friends that would study, biology or chemistry or whatever. And I'd always say to them, what are you going to do with that chemistry degree if you don't get into school? And so I don't know, teach high school, go to grad school, who knows? And I thought, well, at least if this doesn't work out, I'll have music and I can be a college professor and would really enjoy that. And it would be fine and fun and would have no regrets. And so I did that as kind of my backup plan while I was trying to do this.
Very cool.
And so I still play a little bit now. I took about a 20-year hiatus from playing. Have a master's degree in classical saxophone performance. And so I took about a 20-year break. And then over the last couple of years, I've started joining a bunch of retired guys playing. And, even though I'm approaching 50, I'm by far the youngest guy in my saxophone quartet. Everybody else is retired or semi-retired. And we get together and just, play every now and then, do gigs at nursing homes and real low-key events like that.
Very cool.
That's wicked.
Well, I myself am a musician, play quite a few instruments. I was going to bring some with, but I didn't know what you played.
What do you play?
Guitar, bass, drums, piano. I did a little harmonica for a while.
Oh.
Most wind instruments are a no-go for me.
Yeah, I'm the opposite. Most string instruments are a no-go for me. Played a few woodwinds in my day.
Very cool.
Okay, so thing we want to talk about obviously was field terminations. I always feel that sometimes we are pretty good about this, but I know from being an FOS and dealing with that in the field of crews calling and asking the inevitable question of what do we do now?
Yeah.
So what would be some of the, from your perspective of taking those phone calls from our field crews, what do you want to hear? What do you want us to say? To you guys, what exactly are the things you're kind of looking for when it comes to agreeing to field termination?
So I think the number one thing I want to know from the crew is that the crew is comfortable with the situation. The other thing is somebody will call and they'll want to tell a real long, big fat story about how we got here, what the call was, all the things. And really, you're burying the lead. So what I want to know is time. If it's not 20 minutes, where are we talking? So time, rhythm, and end tidal CO2. Those are the three pieces of information that I typically will use to determine whether or not field resuscitation can be terminated or not. So if you tell me you've got PEA of, really in my mind, it's any PEA should probably be transported, although I know the protocol says less than 40 consistently. But if you tell me you've got a PEA with the rate of 60, even though they may seem pulseless, I'm going to tell you to transport. If you tell me they've had VFib at any time during your resuscitation, I'm going to tell you to transport. But if you call and say, hey, I've got asystole since the time we walked in the door and the end tidal's been consistently, less than 20, then that's really cut and dry. right? But all these other kinds of extraneous things, it's just signal to noise ratio, right? It's a lot of noise, very little signal. Just don't bury the lead. Just cut right to the chase, And I always like it when a medic calls and says, "Here's what's up, and here's what I want." Sometimes a medic might need to call and say, "Here's what's up, and I don't know what I want." But that's great too. But just don't bury the lead.
Do you think we tend to do that because I'm standing right in front of a family member and I'm like, I want to tell you all what's going on to make sure that you know all the information.
Yeah.
And so do you think it would help if we maybe stepped away?
Absolutely.
Or do you think that's too, I don't want to walk away from my family member, then just walk back into the room and be like, all right, they're gone, because it may look a little bit insensitive, but.
I think you have to kind of gauge your audience.
Sure.
Right? If you feel like it's the sort of thing where you have to do a little bit of a production for the sake of the family, then that's totally appropriate. Because obviously we need to be sensitive to what's going on around us, be sensitive to the family. There will be times when absolutely you can walk around the corner and have a private conversation, or you could even say, I'm going to step outside where it's a little bit quieter and I'm going to have a conversation with online medical control, right? And then you can have a private conversation. But I think you have to read the room. And I think a lot of probably what we'll talk about today will be reading the room. So I think that's a good segue into some stuff we can talk about.
Okay. This has happened to me a couple of times. Thankfully, not to pat myself on the back, but I was able to kind of assist the family in sticking with the DNR. So we get there. We're pumping chest. They bring us a fully fledged DNR, signed, everything, 100%. And the family wants to override it. Now, I know that we can allow them to do that, but I was able to kind of talk to them and say, hey, you remember this is their last wish.
Right.
I understand that you may want, but without being too callous and saying that there's obviously almost no chance because I'm furthest thing from a doctor. So I'll let you guys decide that. But what would be some things that maybe what are some things that we could tell these family members that are obviously in crisis that could help maybe, I don't want to say coerce them, but maybe help assist them in understanding what that DNR really means?
Right, help them be comfortable with the decision.
Absolutely.
Yeah, I think a lot of families, we see this a lot, they will even say, I know mom signed this thing, but we're not ready to let her go. And sometimes they need a little bit of guidance to the point of you have to help them understand the consequences of the decision they're making. And sometimes the consequence is, if mom survives, what will be the quality of her life? What is the quality of her life now? I notice she's in a hospital bed in your living room, for example. Does mom normally drive and go get her own groceries and go get her hair done and do all these things? Best case scenario, we're not coming back to where we are now, even if we survive. Obviously, the older we get, the harder it is to return to some baseline, right? And so if you help them understand, if she survives, imagine what the quality of her life is going to be. Sometimes that's enough. Sometimes helping them understand what happens during resuscitation. All right, we're going to do CPR. We're going to hurt mom. We're going to break ribs. We might damage her lungs. Then she's going to be on a ventilator if CPR and these medicines are successful. And then she's going to be in the intensive care unit. And even with all of that, even if we do everything the best way we know how, she may not survive. Or if she does survive, she may be discharged to a nursing home or some other long-term care sort of environment. And so, a lot of people who aren't medical, they just don't understand the consequences of what we're doing. They see on TV, right? I've literally had people say, well, can't you just inject some epinephrine right into their heart and bring them back? I wish I could.
It works in the movies.
It does. It works in the movies. And that's what people really think of. And so the problem we run into is that the preconceived notion of people is all based on what they know. And they get most of their information from popular media, particularly if they're not medical. And so you're fighting that when you're having these conversations. And then, on top of that, people have their own reasons that they don't want mom to die. mom has been my rock forever. What am I going to do without her? Or this will make me too sad, or whatever the case may be, right? So there are a lot of things that you are fighting. I think at the end of the day, what I would tell medics is don't fight this too hard. It's really not worth the fight for you to get crossways with the family trying to talk them out of, reneging the DNR. Just bring them to me and let me have that conversation.
Sure.
I do this all day, every day. I'm skilled at it. We're used to it. We're used to these difficult conversations, and I think it's unfair to ask a medic to do this. And the other thing, you think about is a lot of our medics are young. A lot of our medics are very young. And, think about when you guys were early in your career, would you have had the bandwidth to have that conversation? Probably not. And that's why we have field supervisors, obviously. But I think in general, it's just not a fight. I would just say, hey, just bring them.
So with that being said, I know not all hospitals are the same. Not all doctors are the same.
Right.
So we've transported patients before who have a valid DNR to a hospital and kind of, maybe gotten a little finger shake at.
Sure.
Obviously, we're trying to explain the situation that we are bringing you someone who we probably should have pronounced at home.
Right.
But how do you guys, from the hospital side, tend to deal with stuff like that?
I think to your point, we're all a little different. Some of us are pro-medic. Some of us are not.
Sure.
Right.
Been there, seen that.
Yeah. And so the people that fight you are the ones that it doesn't matter what you bring them. You can bring them a stubbed toe who would have done just as well with the Uber. You can bring them an actual respiratory distress for whom you made, a meaningful impact and everything in between, and they're going to hate you because you brought them work. Sure. And so those are the people that you're arguing with. Just let them be. Let them hate their lives. Let them live with their poor choices of career. Let them do them. You just know you're not going to have to go home with them. You don't have to be their friends. You do what you think is right for the patient, and at this point, really, the family is your patient, because you recognize that the actual victim or patient or whatever you want to call them, we're not doing anything useful there. So really, we're taking care of this family.
I'm so glad you said that. So, I've told many a field crew member in my day that, whenever you run up on these scenes like this and they're dead, they are DRTs, what we jokingly call it, but the family won't let you pronounce them. Right. And so you stop becoming a patient advocate and start becoming a family advocate, because that's your new patient, right? So you're trying to help them get through this, because this is not going to happen. So doing everything you can to help them get through this. Yeah. So it's
treat the family and just be honest. Honesty will get you really far, because the family will feel like you're advocating for them. You are helping them understand what's going to happen. Obviously, they're scared. And I tell them, hey, I can't predict the future, but based on my experience, here's what I see happening. Sometimes I will even tell family members, if this was my mother, if this was my sister, my cousin, my aunt, my uncle, my child, here's what I would do based on what I know. And sometimes people really appreciate that connection. If they know you're making decisions the same way you would make them for somebody you care about, I think some people really think that speaks volumes, and I think it's a good way to connect with people.
Humanizing a situation.
Yeah.
Putting yourself into their realm.
Mm-hmm.
Maybe not at an emotional level, but at a logical level.
Mm-hmm. And I think it tells them, I may not understand exactly what you're going through right now, but I'm listening, and I'm trying to help you the best way that I know how.
Right.
So when it comes to DNRs, advanced directives, living wills, and all that stuff, we're told that it has to look like this. It needs to be filled out. It has to have signatures, physician signatures, all those things. What are some things that you that especially from the hospital standpoint, that you primarily see on those types of forms that are either key indicators for us to know that it's valid on top of like advanced directives, what things you might specifically be on the lookout for.
Right. So let's talk about DNRs first.
Sure.
So, when you look at the DNR, the Oklahoma DNR has two sides. One side is the patient or representative initiated DNR. So if I'm of sound mind, I can put my name on the top, I can sign the form, and then I have to have two witnesses. Or let's say I have medical power of attorney of somebody who can no longer make their own decisions. I can be their representative, I can fill that out, and again have two witnesses. One of the keys of the Oklahoma law that I think is interesting is it specifies that it can't be somebody, like a witness can't be somebody who has something to gain from your death, which is always kind of hard to figure out,
Interesting.
particularly when you're going on scene. The other side of the form is the doctor initiated DNR. And so what that says is two physicians have put their heads together and said, there is no reason to try to resuscitate this person. And that is usually done if a patient doesn't have anybody to represent their best interests. But you'll occasionally see that. So one of the things I think we see a lot is the incomplete DNR. It's been started. Maybe I signed it but haven't had a chance to get my witnesses yet. And so it's not a completely valid DNR. Or something I know we see a lot of, which I've never understood, but I know we see this every day. In fact, I got a call from another ambulance service 20 minutes ago with this exact situation, is we've been discharged to hospice. And nobody thought to complete the DNR before we went home on hospice.
Oh boy.
Right? You see that a lot, don't you?
Absolutely.
And hospice, the whole point of hospice is, depending on what condition we're on hospice for, it means we're going to stay comfortable, but we're not really going to fight the good fight on this deal. We're going to let nature take its course. So it gets real confusing when you get on scene and somebody says, yeah, they're on hospice. Well, where's the DNR? They don't have one. Okay. So as far as DNRs go, I think there's the letter of the law and there's the spirit of the law. And so the letter of the law is pretty clear. You have a DNR, it's signed, it's witnessed. We know what to do with that. So the situation that I think we run into a lot, and this is addressed a little bit in our protocols, but I think it makes people very uncomfortable, is the situation where you show up on scene, grandma's in arrest, and the family says, she wouldn't want any of this. We called because we didn't know what to do, but I can tell you she would not want this. And maybe sometimes those patients, their families call because they don't know what to do, and then our fire department friends get on scene and they start pounding on the chest and they're like, oh, I didn't see this coming. I didn't know this was going to be the consequence of calling 911. I thought I was going to call and they were going to help us understand how to take next steps or whatever. And so you may get these families that say, grandma wouldn't want this. Does she have DNR paperwork? No, but we've talked about it and she's told us, she's been pretty clear. So my general consensus on that is, if you're, it's easier for me in the hospital, right? Because that's a controlled environment. Families will come, and we make a lot of decisions based on what kind of input they give us. Well, let's say you're on scene. Generally, the advice I give to medics is this: if it doesn't look like a crime scene, right? So you're not looking around going, this place is real shady. And if everybody on scene agrees that grandma wouldn't want this, I think you're probably okay to honor that. Now, our protocols specifically say you should call us and run it past us. Call somebody. But I think, in general, if that's the situation, if there's nothing there, you got to trust your spidey sense. Trust your gestalt. You've been in plenty of dangerous places as a medic. You know what a place is shady. You know a place that isn't. So you go in there, everything seems to be on the up and up. Everybody in the family agrees, and they're not standing around with the checkbook open. Nobody's standing there, digging through the safe, counting the silver pieces or any of that kind of stuff. I think it's probably okay to assume that that's legit. You know what I mean? However, if your spidey sense says something's not right, your spidey sense says this is a crime scene, your spidey sense says I'm really uncomfortable, or there's even one dissenter in the room, then I think you just got to do it. You just got to work. And I would probably transport that patient. Even if they meet termination criteria, I would still consider transporting them. Anytime your spidey sense says termination criteria or not, I got to get them out of here, trust your gut. Right? We'll never fault you for transporting somebody who meets termination criteria if your gut says we got to go.
Sure.
Yeah, I think sometimes you find yourself somewhere in between meeting your protocol standards and what the patient and what that situation needs at the moment. And sometimes you're right there in the center of it.
Mm-hmm.
So definitely trust in your gut. Do you discourage people from calling in those odd situations where we find ourselves in the middle of the gray area?
Call 100% of the time. I think you should absolutely call. I think we're all happy to take your call day or night. The reality is we want to help protect you. And we can't protect you if you don't call us. So if there's ever a situation where I just don't know what to do, or my gut says maybe I should do this, but it kind of doesn't really jive with the protocol or whatever, let us help make that decision. I'd rather that decision ride on my back, help with the liability standpoint of that, help with the after action complaint that might come from the family or whatever. I'd rather own that than have you guys own it. But if you don't call me, I can't help you. If you call me, we can talk about it, and then we can be in the thick of it together when something happens later.
Yeah. So we've talked about DNRs. How about Advanced Healthcare Directives? How do those differ?
Mm-hmm.
What kind of things are we looking for with those to direct our care?
So here's where I get a lot of calls, is not so much the healthcare directives, but the one component of it, which is the medical power of attorney. And I think there's some confusion of what a medical power of attorney actually is. There are a lot of people out there, a lot of family members who believe once the form is signed that identifies them as the medical power of attorney, that now they get to make all the decisions. But that's not the intent of that piece of paper. The intent of that piece of paper is you get to make decisions once the person who's the subject of it can no longer make those decisions on their own. And so I'm sure you've been on scenes where you go to somebody's house, whatever, right? Family member calls, they're worried about grandpa. You get out there and grandpa says, I'm not going anywhere. I'm 80 years old. I know I'm long in the tooth. I don't have much life left. Today might be my day. Tomorrow might be my day. A year from now might be my day. But I don't want to go to the hospital. And they know who they are. They know where they are. They know what's going on. They know why you got called. They understand the consequences of not going to the hospital. So for all intents and purposes, they meet the criteria to make their own decision, right? And then you'll have a family member waving this piece of paper. I've got the medical power of attorney and you're taking him to the hospital. In fact, we're not, right? And so that's the thing I see the most that kind of comes up in these conversations. Because the rest of the advanced directive is things like, if I'm unconscious, are you going to tube feed me? Are you going to give me fluids? Are you going to do these other things that typically don't really apply to what we're doing on the emergent or urgent basis. But the thing that applies is that medical power of attorney. And I think medics really need to understand what that is, what it's for, and that it's okay to say, this situation does not apply to that. And again, if there's ever confusion, call your FOS, and if they can't help, call one of us, and we'll talk through it. And I am more than happy, and have done so on occasion, hey, put me on the phone with the family member, and we'll talk through it. A lot of times it's just a misunderstanding. They just don't really understand what that paperwork is for. And when you explain it to them, and you say, I really understand where you're coming from. I get it. I think your dad should go to the hospital too. In fact, I got on the phone and told your dad he should go to the hospital, but he's capable of making decisions, and unfortunately we can't kidnap him. If you want to call us back when he can't make decisions, or if he's unconscious, we'll be more than happy to take him to the hospital. but as it stands right now, we're stuck. And you help them understand that, you recognize their frustration, help them understand that your hands are as tight as theirs. I think we can get through a lot of these conversations without, too much kerfuffle.
So I can think of something, DNR versus DNI. That's something that comes up a lot with, say, you respond to grandma and she's a GCS of 3. You don't necessarily have DNR paperwork, or maybe you have a DNR, you don't have Advanced Healthcare Directive, and you're in this middle space of how invasive do I get with this patient?
Right. There's 2 answers to that question. If there's family around, let them guide you. They'll usually know the answer, and document that conversation. So family's around, grandma has a DNR, she's in respiratory distress, normally you would intubate her. Or, grandma's hypotensive, you would normally start pressors, whatever, right? Some invasive, aggressive kind of treatment. And so the conversation, if there's family around, is here's what's happening. If we don't intervene, she's going to probably die. If we intervene, then we can prolong her life, and she may have something reversible. I don't know. I can't predict the future. So if we intubate her, it might be that this is a short-term Band-Aid to get her better, and it might be that this is the last thing, grandma experiences. So families will be pretty good at guiding you, and they will often say, no, she wouldn't want that. And if that's the case, I'm good to go with it. Families might say, we understand that intubation is invasive, but we're willing to let her be intubated for a couple of days and see if she turns around. Also reasonable, right? DNR does not necessarily preclude any of those things. DNR specifically is saying if my heart stops beating. And so there's this bit of a misconception that DNR says, I don't want to be aggressively treated. That's really not what it says. A DNR is saying, I don't want to have CPR, electrical shocks, things like that. It's not saying don't be aggressive if I have something that's potentially reversible. So families present, talk to them, get their guidance, follow their lead. That's the safe thing to do. That's the safe play. If there's nobody there, DNR's hanging up on the refrigerator, which sometimes happens. They're not dead. Do your things. And then we'll sort it out on the back end. If you intubate somebody, you do all the things, we get to the hospital, get in touch with family, and they say, she wouldn't have wanted any of that, we can extubate him. It's not a big deal. So, the high road is take care of what you see in front of you.
Yeah. Now, what would you say as far as provider confidence? Because it's a weird place to be. You bring an unresponsive patient in, and either you've intubated them and you have a valid DNR and you slap it on the table and the doc says, why are you here? And why is she in this shape? Or, and the opposite end of it, you bring an unresponsive patient without an advanced airway and they're looking at you like, why did you do nothing?
Right.
I
think ER physicians appreciate critical thinking. And my general approach is if you can help me understand your train of thought for why you did or didn't do something, then we can work with that. One of the things I think, a lot of providers in the emergency department, they don't understand what it is actually a medic does. Imagine the number of ER nurses who have never been on a single EMS ride. Not one. The number of mid-level providers who have never been on an EMS ride. Not one. When I get students come rotate with me, whether they're PA students, nurse prac, whatever, I send them on an EMS ride. It's important to know what it is you guys do, because people don't recognize that you're making very complicated decisions with little to no information in a strange, uncontrolled environment. And I remember the first EMS ride I ever did as a resident. And it completely blew me away. Like, it changed, first of all, it started my love of EMS, and it's why I'm sitting here, but it also completely changed my perception of the care that is provided in the field. And the big message I walked away from the rotation with was the fact that these folks can get the amount of information that they can get and provide the care that they can provide given all of these obstacles is freaking amazing, right? But a lot of people working in the ER unfortunately don't understand any of that. They don't recognize what it is you actually do. And all that to say, so it's a long answer to a short question. I think people just respect communication. They respect critical thinking. And I think one of the things that happens, and I used to see this when I worked at an unnamed hospital in Oklahoma City, medics would come in, and depending on who was working, they would drop their patient and run off because they knew whether they had done everything right or they had done everything wrong, there was going to be some kind of a battle. Why'd you come here? Why'd you do this? Why didn't you do this? Kind of like you're asking. And it didn't matter what they said, it was going to be a battle. And so I think one of the things that happens then is medics get in the habit sometimes of being like, this is a iffy decision I made, and depending on the luck of the draw and who's there to receive the patient, I may have made somebody mad. I'm just going to drop them off and get. Drives me crazy when medics drop them off and get. Mm-hmm. I love being able to talk to medics who bring me my patients, because I understand then, I get your perspective. What did you see? What did you hear? What did you think? What did you do? Why'd you do it? Why didn't you do what you didn't do? Otherwise, I'm left to tell myself a story. Right? And rule number 1 of crucial conversations is don't tell yourself a story. Right? But if you don't give me the information directly, if I've got to play the telephone game and everybody gets to tell their own version of the story, then by the time it gets to me, well, they were just lazy. They didn't want to deal with it, right? That's the answer at the end, is they just didn't want to deal with it. Where maybe the answer actually was, no, they dealt with it given the information that they had and made the best decision they could make. The advantage I always have at the hospital that you never have is I have a electronic medical record where I can go back and I can see what's been going on for years with that patient. I can see doctor's visits and medications and procedures and all these things. Patients somehow never know anything about their own history. Families will tell you that somebody had, some crazy procedure because they heard it named on TV, and the reality is they had nothing anywhere close to that. They'll tell you, oh yeah, they had open heart surgery. No, they had an angiogram. Right? Yeah. Big difference. And so just be confident in your decisions. Sometimes you'll get it right, sometimes you'll get it wrong. If you ever get somewhere and somebody's, a big fat jerk to you, don't fight. There's no reason to fight. Just let them have their moment. And then if you want to talk about the call me and we'll talk about it. And I'll be honest with you. If you made a good decision, I'll tell you. If you made a less than desirable decision, I'll tell you that too. But I won't yell at you. It'll be completely educational. Nothing good comes from a fight, though. Nothing ever comes good from a fight. So don't be defensive, I guess, is the bottom line. Just provide the information, communicate what you did, what you saw, what you heard, what you thought. Let them do with it what they want. And if they disagree, hey, more power to them. It's their prerogative.
Take it in stride and learn what you can from it.
That's right. And sometimes, the whole thing is you got to be honest with yourself. Right? So if you call me and I provide you feedback and you argue with it the whole time, it tells me you're not being honest with yourself. Right? People who really want to excel, who want to get better, will take the feedback and then internalize it for a couple days. And those people who really want to be at the top of their game, they do so by admitting that they made a mistake. When a paramedic graduates from paramedic school, You are literally graduating as an entry-level paramedic with 0 seconds of experience. Nobody expects that medic to make the same decisions that a 5-year medic makes, or a 10-year medic, or a 20-year medic, right? I think one of the lessons is that this is called the practice of medicine, because every time we do something, hopefully we do it a little bit better the next time, right? Every time you see a patient, you should say to yourself, okay, had this patient, they had this thing, I did this thing. What did I like about that? What did I not like about that? If I could do this all over again, would I have done anything differently? And if you're being honest with yourself, the answer is often yes. Sometimes the answer is no. I think I finally have figured out how to treat this thing the way I like. I think I finally have my practice pattern. And that's cool. But you've got to be willing to admit there are a lot of ways to do things. And sometimes somebody might have a better way. But if you fight them, you're defensive, you're not going to learn that better way. So.
Yeah, I feel like there's always something to learn. That's the beauty and the terrifying part of this field, is that no 2 days are ever the same. And sure, you may run the same call 20 times, but that 21st time may be something completely different than what you thought, and it throws you for a loop.
Yeah, I think, a good example of that is like crosstown transfers, right? You get dispatched to a crosstown transfer and you're like, another transfer. And so you get complacent. You're like, they've already been stabilized, whatever. Some of the most complex calls that I get from medics is transfers, especially long distance transfers. Some of my services are rural services, and so I'll get a call from somebody going on a 50-mile transfer on a critical patient, and then they'll call with all these things happening, and they're completely out of ideas. And so now what do? We've got to use the tools that are inside the ambulance, the medicines that we have, and we've got to MacGyver a solution. Those can actually be pretty challenging calls.
Oh, yeah.
But if you approach them with, it's just another transfer, that's when you get in trouble. And so, any of these calls you can approach with, it's just another this, it's just another that, and then you get completely sideswiped by something you weren't expecting. And, so absolutely, there's always opportunities to learn. I've been doing this for 20 some odd years, and, every day is a learning opportunity.
So we had talked about hospice care.
Yeah.
And I know that that's kind of got a stigma with hospice people going to the hospital, that they'll magically lose all their hospice care and that they won't do any of those things. My question is, how true is that? Does it matter if they go just one time, or is it like, hey, they got the punch card and they go, oh, you reached the 10th one, you're out? It's like.
So that's a really good question. I think there's a lot of confusion surrounding hospice. And this is a huge gray area. There's not always a black and white answer to this. So one of the things to keep in mind about hospice is usually when you're on hospice for a specific condition. And it's not like you're just globally on hospice. So if I go on hospice because I've got end-stage COPD, for example, that doesn't mean that if I have a heart attack, I can't go get treated for that, right? Doesn't mean if I've got belly pain, I can't go get treated for that. Those things are exclusive of the hospice. Sometimes I may have something going on that everybody thinks is probably reversible. So even though I'm on hospice for end-stage COPD, I'm more shorter breath because I've got pneumonia, which can be treated with antibiotics. So couple scenarios. One is you can obviously go for anything not related to why you're on hospice, and that's the easy scenario. Then sometimes you can go for things that are kind of tangentially related, that maybe have a short-term solution, reversible cause. And then sometimes you can go for respite care. Maybe the situation is, I want to feel better for a few days and I need to be in a place where I can have aggressive pulmonary toilet and some medications for my anxiety and things like that. And usually they can do all that with hospice at home, but occasionally the hospice will be like, why don't you go to the hospital? We will pause your hospice while you're there, and then we can start it back up. hospice has gotten kind of loose over the years. When hospice was first something that we started seeing a lot of, it seemed like it was pretty rigid. Seemed like it was an all or nothing sort of thing. And I don't know if that's what it actually was, but that was how it was always portrayed. And I think the reality now is it's really system based. I'm on hospice for my brain tumor, my whatever. So there will be patients that, in spite of being on hospice, are going to call 911. Now, here's a general rule that I would probably provide the medics. If you are called by somebody who's on hospice, number one, find out what they're on hospice for. If the call is unrelated to what they're on hospice for, just do your usual thing. Treat, transport, don't worry about it. Just make sure the ER knows they're on hospice for XYZ, because we will contact the hospice folks and make sure that they know they're in the hospital. If you get on scene and the patient is stable and they tell you they're on hospice for whatever, I would ask them where the phone number is magnetized, because it's usually on the refrigerator or the kitchen counter or something, and I would call hospice. And I would just call them, introduce yourself, let them know why you're there. Sometimes they're already aware. Oftentimes the patient will call first. And if they say I've already called hospice and they said to go to the hospital, great. But ask, did you call hospice before you called us? And if the answer is no and the patient is stable, call hospice and see what they have to say. Because sometimes if the patient is just feeling anxious because they're more short of breath and really what they need is to go up a couple clicks on their oxygen and have an extra shot of Ativan, hospice will tell you that. And they'll say, hey, put Johnny on the phone, let me talk to him. We go through this every couple weeks. And they'll tell Johnny, hey, buddy, here's what I want you to do these things. And Johnny will be like, okay, you're sorry. You're right, I'm sorry. I got freaked out. I didn't know what to do, so I called. And then you can work through it, and then it can become sometimes a no transport. Again, if you're ever nervous about it, call us. We can talk through it. But definitely involve hospice if there's any way possible, because that might save a lot of heartburn downstream. It might prevent an unnecessary transport, might prevent some unnecessary confusion. And I think it's important to clarify when I say they are stable, what I really am saying is, can I treat in place for a minute while I call hospice? Is this something that I can manage by doing my usual routine things? Can I increase their oxygen for a minute, and is that going to settle things down? Can I keep them safe while I call hospice? If the answer is no, then just get out of there. Just take them, and we'll deal with it on the back end. But communication with hospice, they really appreciate. And I think you'll find that when you call hospice, they're the nicest people on the planet. People don't go into hospice unless they have a certain kind of heart and mindset. And so they're grateful for the call.
Sounds like we'll have to kind of lean on our assessment skills and figure out, is this patient too sick to sit here? And then if they aren't, they can stay. Then call hospice, ask questions. It's crazy. That's
assessment skills. What's that?
Well, hang on. That's a whole nother podcast.
You mean stethoscope?
It's in the truck.
Yeah. Sometimes it's more than just an ornament.
Right.
It's true.
Just a costume piece.
We've called you. We've terminated.
Right.
So now the next steps, what would be some things that maybe you could help in your experience explain to some of these, like you said, newer medics, newer people,
right,
that have probably never told a family member that they're dead, and how to kind of progress with that. In my expertise, the many times I've had to do this, is I always tell them, hey, we've stopped, they are gone. What I can do is that in Tulsa, the police department's going to come out. They come out to all of these just because they have to walk in and give it the whole, it's not a crime scene thing. Yeah. If you'd like, they can call for a chaplain, some things like that. Other than that, is there anything else you would need for us to do? Please don't cover up the body, things like that, because until PD gets here and says it's okay.
Right.
But from your expertise, especially dealing with the hospital, what is what would you maybe tell some of these newer medics to kind of start looking towards? Or
so I think there are some certain things that you can do every time that will make this easier, bearable, not any fun, of course. This is probably the hardest thing we do, is telling somebody that their loved one has died. So some things that help is, number one, get on their level. If they're sitting, you need to sit. And that might mean that you're kneeling in front of them. But if there's a place you can sit somebody down, be seated eye to eye. That's step one. You never want to be elevated, right? You don't want to be standing over them. So always sit down. Number two is sort of the bad news pause. And what that looks like is, I need to give you some bad news. What I need to tell you, right? So there's this kind of pause where they know some bad news is coming. They have a second to be like, oh, there's something coming, right? Get a little bit ready for it. Oftentimes they know what that bad news is going to be in this particular situation, right? I think the other part of this is you need to be very clear and direct. And the words that you choose are very important here. And they sound harsh, but all the literature, everything I've ever read about this, all says the same thing. Don't say they've passed away. Don't say they've gone to heaven. Don't say they're gone. Don't say any of that. Anything that could be confused. You have to say, I am sorry, but they have died. There's no mistaking, they have died. Right? So I think for me, what it is I am so sorry to tell you this, but Johnny has died. We did everything we could, but unfortunately, we were not able to have a positive result. You know, whatever it is you want to say. I think they need to know that you're sorry. I think they need to feel a little bit of empathy from you. And, you know, in the short term, it's going to be shocking for them when you say, I'm so sorry, but Johnny has died. In the long term, they're not going to remember the exact words that you said, but they will remember how you treated them. And so, you know, one of the things that is particularly difficult for you in this setting is it's loud and there's people everywhere. You've got a truck full of firefighters. You've got, you know, a couple of medics. Maybe there's a cop there. I mean, there's all kinds of people in there, right? The advantage I have in the emergency department is I take them someplace quiet. I take them to a family room where there's just me, maybe the nurse, plus whatever family, so we can have a quiet, non-distracted conversation that isn't rushed. So one of the things, if you could try to get them someplace where it's less noisy, I think that's useful. But again, sit down face to face, eye to eye, and don't be rushed. I know we get in a hurry sometimes. We're trying to get back in service, calls are holding, all of the things. But the last thing you want to do is say, well, yeah, I'm so sorry, Johnny died. Got any questions? I'm out. Right? That's not going to fly. You know, that's going to send a message that we just don't want to send. And so this is the time where you're going to be stuck there for a while probably. And I like your approach of learning what happens in your division so that you know, if I'm in Oklahoma City, here's what happens. The police will come, they will call the ME, they may have some questions, the ME will call back, and they'll let us know what to do. They may want to come get Johnny and take him for a viewing or an autopsy, or they may release him to a funeral home. I think it's important to just kind of walk them through that process so they know what to expect for the next couple of hours. And then I think it's also very good form to ask this question. Is there anybody I can call for you right now?
Mm-hmm.
Right? Because I think if you ask the question, is there anything I can do for you right now? They may have a hard time answering that question. Have you ever heard these things where, you know, you have a friend, a coworker, whatever, who's gone through something traumatic at home? Maybe they've lost a loved one, maybe their family member's sick in the hospital. And if you say to them, let me know if you need anything, they're not going to let you know because they don't even know what they need, right? You have to be very specific with the question. And so these folks, they're in shock. Mom just died. So I asked them very specific questions. Is there anybody I can call for you? Do you have a sister, a best friend, something like that? Give them some choices. Somebody that you might want me to call. Do you have a minister that you would like me to call? At the hospital, I'll often say, would it be helpful for you if I got the chaplain to come talk with you? Right? Give them very specific choices. But if you say, what can I do? Is there anything I can do? I know we like to give people open-ended questions generally, but this is not the time for that. Specific questions. But definitely do a needs assessment and help facilitate whatever it is they say. And I think that really goes a long way. So that would be my recommendation.
So outside of the phrasing dead versus passed away, any specific verbiage that you would use outside of that?
So sometimes I will ask them what they know before I tell them anything, because I want to sort of gauge where we are. So particularly, let's say at the hospital, somebody might have respiratory distress, EMS is called, the last thing anybody knows is they left there short of breath, and now I'm getting ready to tell them that they've died. And so I want to know what they know, because I don't want to over-tell them things, but I definitely feel like I need to close the gap of their knowledge. That helps families with closure. And so in that situation where they don't know anything, I will bring them up to what I know, the details I feel like they need. Do they need every last detail of we did this, then we did this, then we did this? No. But, let's say they've called 911 for cardiac arrest. Or let's say they call 911 because their loved one is unresponsive. We get there, we find out they're in cardiac arrest. So what I will say is, tell me what you already know, and then I'll fill in the gaps. And I'm just very clear with them. Tell me what you know so I can fill in the gaps, right? That's why I'm asking you what you know. I'm not trying to be a detective. I'm not trying to, pick on you. Just tell me what you know so that I can fill in the gaps. And so then she might say, well, Johnny hasn't been feeling well the last couple of days, and then he passed out, and so I got scared and called. And that's all she knows. So then you say, okay, so when the first arriving responders got here, when they found Johnny, he didn't have a heartbeat. So we did CPR. We gave him all of the medicines that you would normally give for CPR. We breathed for him during all of this. We did all of the things that our protocols would have us do that we would do for anybody else in the same situation. And in spite of that, nothing worked. I'm sorry to have to tell you this, but Johnny died. Right? Otherwise, if you're just like, she calls because Johnny was unconscious, and the next thing anybody says is Johnny died. What? What do you mean? Like, he was talking to me just before I called. What do you mean he's dead? Right? She deserves to know kind of the chain of events, right? So I'm very careful to fill in the gaps. She doesn't need every horrid detail, but she needs to know something, right? I think that's fair. So that's kind of my approach, just gauge what they know and then work off of that. If she says, he passed out, I couldn't feel a pulse, I figured his heart had probably stopped, so I called 911. Okay, well, that's a different conversation, right?
Right.
Because she knows when she calls that he was already, largely dead when she called 911, and he stayed dead. That's a different conversation than he was alive, and now I'm telling you he is dead. Honestly, those conversations where they already know that he's dead and they're just waiting for you to tell them, those are easier conversations because you're just confirming what they know most of the time. Sometimes there's still hard conversations, but most of the time, they already know, and you're closing that communication loop.
Yeah.
Right. The hard ones are where they were awake at some point recently, and now we're telling them they're dead. But I think, recognizing that these situations are all different from one another, You've got to know your audience. You've got to assess their knowledge, and you've got to speak to them in a way that they understand. And if it's a family that does not speak your language, you need a translator. And the translator should not be the child. Should not be, anybody who's not old enough to drive a car should not be translating in this situation.
That's a great point.
So, it's unfair. We do this. We're all bad at this. We'll have a Spanish-speaking mom, an 8-year-old who speaks great English, and we're asking the 8-year-old very personal questions about mom's medical history. We shouldn't do that. That's not fair. That's not right. It's not fair to anybody. And then especially when you start getting into complex things, we're going to do a death notification through a 10-year-old who's translating.
Are you trying to say that parents hide things from their kids?
Occasionally.
Sorry, I interrupted you. Go ahead. But obviously, yeah, I couldn't imagine trying to ask a kid to translate to someone that grandma had died.
That's right.
They might not understand what they're saying.
Yeah.
That's crazy.
And so let me give you another, just kind of on a personal note. So my father-in-law is a smart guy, pharmacist, had his own pharmacy for years, speaks medical. His brother, pharmacist, smart dudes, right? So they're both long in the tooth, getting up there in age, and so his brother had some health problems, ended up in a local rehab hospital. So one day my father-in-law's up there visiting his brother, and the brother dies. And so the rehab people call 911, and crew comes, and my father-in-law says, "Hey, please don't do this. I know we don't have a DNR, but he wouldn't want any of this. We've talked about it." And the crew completely ignored him.
Great.
So I think there's a lesson there, right? Read the room. Understand your audience. There are times when absolutely it's appropriate to ignore the family because it's just not safe. It's your spidey sense says, mm-mm. But there are times when you've got a gray-haired old man standing there who's not yelling at you, who's speaking intelligently, who's speaking the same language that you are in terms of medical things, probably knows what he's talking about. And then the crew ignores him. So 2 years later, what does my father-in-law talk about his brother's death? Is how that crew ignored him. Mm-hmm. Don't be that crew. Don't be that guy. I think if you will approach every single situation, and I don't care what it is, stub toe all the way through cardiac arrest. This is my mom, dad, brother, sister, aunt, uncle, nephew, niece, child. What would I want to happen to them? That's what should happen to your patient. Unless you hate those people, then don't do that. Pick somebody else you like. But the point is, if you make decisions based on how you would want your favorite human being to be treated, you will never go wrong.
It's back to the age-old saying of treat others the way that you want to be treated.
Weird.
Funny.
Yeah.
Well, Doc, thanks for coming in. We really appreciate all this information.
It's my pleasure.
It's really eye-opening. A lot of good information to chew on and take into our everyday calls that we run.
I can't wait to get this out to everyone so they can, just experience what we've just sat through. Lots of really good information. I hope maybe it'll help them to where they'll be able to call you and give you exactly what you guys need to kind of help pass this. It's a hard subject to talk about, but I'm glad we were able to do that, and we appreciate you.
Well, thanks for the invite.
Absolutely.
Hope you'll have me back. I really enjoyed it.
100%.
Absolutely.
Had a great time talking to you guys today.
For sure.
Well, my name's Cody.
I'm Brett.
And we'll see you in the next shift.
Thanks for your service.